Hi, I'm Rob Seltzer with Aortic Hope, and we are here tonight with Maysoon Dayoub from Cook Medical, and we're going to talk about their company and the things that they do to with aortic disease and the products that they've developed and manufacture. So first, before we do that, let's get a little housekeeping out of the way. Aortic Hope, we're a 501c3 that is here to support and help survivors and family of aortic disease. So please, if you are watching now live, or if you come back later and watch us on YouTube, if you would hit the like button, that would be great, and share. And also there is a donate button. As a 501c3, we work strictly on donations, and we are all survivors. So if you have that ability, please make a donation to help us continue with our work, just as Cook Medical has done, as they are now a sponsor of Aortic Hope. And we truly appreciate their generosity towards our group and our mission. So let me tell you a little bit about Maysoon. Uh, Maysoon Dayoub. She's a PAC, I think in cardiology with an MPAS. She's a seasoned healthcare professional, as she's told me, with over 22 years of experience as a physician assistant. She earned her Bachelor of Science in Physician Assistant Studies from Philadelphia University in 2001, and later completed her Master of Physician Assistant Studies at the University of Nebraska Medical Center in 2011. Most of her clinical career has been focused on cardiac and vascular surgery, with the last decade spent as an aortic program coordinator in the Philadelphia region. Aortic disease has always intrigued her. It's been her love, her passion, not just from a clinical perspective, but because of the lasting relationships she built with patients along the way. We were just talking about that, and she told me how much she, follows them and even gets now invited to family events. And that's the relationships we like to have with our physicians and medical professionals. Those connections have given her a unique firsthand understanding of what patients experience through diagnosis, treatment, and recovery. So today, Maysoon serves as the market development manager in aortic therapy at Cook Medical, where she continues to advocate for patient-centered innovation and helps connect clinical and sales teams with tools they need to bring this innovation to the field and spread aortic disease awareness. That was a lot. Yeah, you've done quite a bit, and we do appreciate the work that you do uh, for us and for Cook Medical. Now, Cook Medical, why don't you tell us a little bit about what they are? And because I'm sure I'd never really heard of you until you came to Aortic Hope.
Sure. Thank you for having me on, Rob. This is a great honor. Hello to the audience at home. I actually joined Cook Medical about 2.5 years now as a market development manager, but Cook Medical actually in 2023 celebrated its 60th year in business. And so it was founded by Bill Cook and Gail, his wife, in 1963. Believe it or not, they started out of their apartment in the spare bedroom in Bloomington, Indiana, where they first, I think, started developing guide wires for angiography and catheters. And I think Mrs. Cook was like one of his first quality control people, if you will, and it has since spread from there. And so we're actually an international, still privately held company. Carl Cook is the CEO, still family owned, but we have 12,000 employees globally. We manufacture both vascular-based products for aortic disease, as you're well aware, as well as peripheral vascular disease. And we also have a med-surg division. And so we are available in 135 countries and counting. So it's been quite, I was telling you earlier, it's been quite the exciting ride to be a part of this and to continue to advocate for patients and to continue to bring innovative products to the market and be a part of the team.
Oh, that's great. That's pretty amazing. Starting in your home, your garage, another little
Yeah.
garage startup stories, and look where they are today. I'm sure they had no, idea that this is what it would become. So,
Yeah.
what can you tell us about the products and such? I'm sure you have some material for us to.
Yes. Yeah, actually, if you don't mind, Rob, I'm going to share my screen. I've actually prepared kind of an introduction, understanding that Aortic Hope is a wonderful organization that not only works with survivors, but family members, friends of survivors, and the greater community. So I'm just going to let me know if you can see this, but I'm going to touch on aortic disease in general, just to kind of help educate our audience. And then I'll touch on where Cook kind of falls into this in general in terms of endovascular treatment and the products that we develop. And you see my screen okay?
Yep, we see your whole screen. If you can put it possibly into a full slideshow,
Oh,
would be
great.
great. If not,
And so
okay,
first, and then try to go back.
there you go.
Because I can, oops.
You saw that note, Maysoon, you're freezing up again a little bit, so you may want to just turn your camera off.
Did I lose you, Rob? Are you still there?
We're here. You're frozen again. You hear me? Try that chat again. Mason was having some problems before we logged in, so let's just give her a minute. There's some connectivity issues on that end, which is not unusual these days. So we're really
Okay.
there. Yeah,
Did
so
I
you may
lose you
want to,
there? I think I'm
yeah,
back on.
yeah, you're frozen. Josh suggested that maybe you want to turn your camera off while you share to
Sure.
use less bandwidth, and that may help.
Okay. All right. So
Just try
you can
sharing.
still hear me okay?
Yes,
Yep.
absolutely.
Okay, let's do that. Because I completely was booted off. Let me try to share it this way. Okay. Okay, just let me know if you can see that, and I will put it into presenter mode.
Yes, we do see the screen.
Okay. Okay, how's that?
Great. That is
Excellent.
that.
Sorry about our technical difficulties here.
Probably turn mine off, so I'm
Yep.
tracking.
Okay, so let's start with what is an aortic aneurysm for our audience. An aortic aneurysm, as many of you may already know, is a weakening in the wall of the aorta with the eventual development of a bulge. Over time, it grows and it causes thinning of the aortic wall. When the aortic aneurysm occurs in the thoracic aorta, or in the part that is here in the chest, we call it a thoracic aortic aneurysm. And when the aneurysm occurs in the abdomen, it's called an abdominal aortic aneurysm. It is usually slow growing, but does need to be monitored. And sometimes a thoracic and an abdominal aortic aneurysm may be seen as one connecting aneurysm, and those are called thoraco-abdominal aortic aneurysms. Now, certain risk factors can predispose to rapid growth, and so patients have to be closely monitored. We do talk about things such as lifestyle and family risk factors as well that can affect aortic growth. But it is important to understand that everyone's needs and every individual's is special and different, and we take all of that into account when we work on diagnosing someone with an aortic aneurysm. The broader list of risk factors include lifestyle, things like smoking, but it also includes things that sometimes folks can't control, which is male gender, family history of aortic disease, heart disease, structural abnormalities such as a bicuspid aortic valve, and a history of high blood pressure. If we look at thoracic aortic aneurysms first, by the numbers, aortic aneurysm and dissection in 2020 unfortunately caused greater than 17,000 deaths in the United States alone. The prevalence of aortic disease is believed to be increasing over time, with estimates that up to 3% of the adult population aged greater than 50 years may have a dilated thoracic aorta. And here I just show all of the different types of aneurysms that can be diagnosed in the chest, in the thoracic region. And that includes starting from the aortic root, which if you can see my pointer here, really is kind of where the heart connects to the aorta. You have the aortic valve there, and then the aortic root. And then you can see here in the ascending aorta, in the aortic arch, you can have aneurysms of the descending aorta, and then of course a thoracoabdominal aneurysm, which encompasses the thoracic parts of the thoracic aorta and the abdominal aorta. If we also look at abdominal aortic aneurysms by the numbers, smokers are more likely to develop an abdominal aortic aneurysm versus non-smokers. So again, it's the lifestyle, and there is also, genetic history that we have to take, family history, male gender. So, and then also just in terms of high blood pressure and heart disease and those risk factors. Unfortunately, approximately 200,000 people are diagnosed with abdominal aortic aneurysms each year in the US. And it's estimated that 1 million are actually undiagnosed and just living with an abdominal aneurysm. Unfortunately, we used to often say that aortic disease is silent until it's not, which basically means when aneurysms become an emergency, then that's when they're not silent. But a lot of people can go undetected and undiagnosed and not know it. In 2017, 6,274 people in the US alone died from an aortic aneurysm. And so how do we treat thoracic aortic aneurysms in particular? Historically, open surgery was the way to go. In fact, it is still done that way for aneurysms that are more proximal in the chest area, such as aneurysms involving the aortic root or the ascending aorta or the proximal arch. Sometimes you'll see that patients will have hybrid procedures where parts of it are open and then parts of it are endovascular in nature. Now, when I say endovascular, if you see here where there's an image of a catheter and a stent graft, this actually was revolutionized in the late 90s, early 2000s. We've been really fortunate to have these modalities, and they just continue to get better and better as the technology advances. But this is a minimally invasive way to approach fixing the aorta if the person's anatomy and risk factors are amenable to fixing it this way. And so it really depends on where the aneurysm is located, the patient's risk factors, their ability to tolerate open surgery, and so on. So these are important conversations to have with your surgeons. Of course, the medical management is also an important piece for this, with whether it's surveillance, kind of like what I did in terms of follow-ups of patients who hadn't yet met criteria to have repairs, or whether patients had already had repairs and now we're in their post-op recovery. Medical management is important. We have to manage the heart rate, manage the high blood pressure. If a person has high blood pressure, that's obviously a risk factor for this. And then, of course, if the person had surgery, and we have to manage things like blood thinners temporarily, so that's important as well. And so what does Cook provide in the arena of endovascular repair when it comes to thoracic aortic disease? Well, earlier this year, Rob, we launched the Zenith Alpha 2 endovascular device. We did have our original Zenith Alpha, and this is an iterative update. I'm excited to announce that this is the first device on the market that has a CO2 flushing option. And what that means is that, devices across all companies, particularly when you go to open these or deploy them, they all have tiny bits of air in them. And in our quest to minimize air in the system, we developed a CO2 flushing option to disperse that, so that, understanding that patients oftentimes are coming back for 1, 2, or 3 aortic procedures throughout their lifetime, we aimed to provide this enhanced flushing option to minimize that air in the system. This particular graft is indicated for patients that have aneurysms or ulcers of their descending aorta. Which leads me to the next aortic disease that can occur other than aneurysms. This particular one is a little bit scarier because most of the times it's an emergency, as you're familiar with, and that's an aortic dissection. And so what that means is it's a tear between the layers of the aorta where the walls separate, and it allows blood to flow not only through the true original channel, but through the false channel here. And so the aorta has 3 layers. It has the innermost intima, it has a middle layer, the media, and it has that outer tissue layer called the adventitia. Your aorta as a tube is meant to handle your blood pressure, the body's pressure. And so it's meant to handle that. But over time, with the risk factors we discussed, or with a known aneurysm, the walls can thin and you can have a dissection. Or if you have super high, uncontrolled high blood pressure as well. But it's all in the timing. So when patients have an acute aortic dissection, it is potentially life-threatening. It requires a diagnosis immediately after symptoms appear in order to get the right treatment. During acute dissection, the mortality is high if left untreated, particularly in type A's, which, occurs in the front part of the aorta, where I mentioned the aortic root, the ascending aorta, and the proximal part of that arch. In fact, 25 to 30% of folks, unfortunately, can pass in the first 24 hours of a type A dissection if it's left unaddressed, and that mortality can reach as high as 50% in the first week. Type B dissections kind of depend on whether or not they're complicated, uncomplicated, if folks are having a drop-off of perfusion of blood to their bowels or to their kidneys and so on. So with the type B dissection, which occurs kind of in this part, the descending aorta, and on down through to the abdomen, that can be managed in a couple of different ways. And so how do we classify aortic dissections? I mentioned type A and type B. And so we have type 1 and type 2 here. Stanford type A means that it originates in that front part of the aorta closest to the heart, notably in the ascending aorta usually, and it can propagate all the way down into the abdominal area, into the pelvic area, or it can strictly stay up in the chest region where the aortic root and ascending aorta live. And then you also have type B dissections, and that primarily originates here in the descending aorta. And that can also propagate all the way down through the abdomen and almost to where the bifurcation, or where the aorta splits before the blood vessels go down to feed the legs. And so if we look at aortic dissection by the numbers, there's approximately 2,000 new dissections each year in the US. They are most common for men in their 60s and 70s. But I do want to highlight something. Greater evidence of malperfusion. Remember, I said that drop off of blood flow that can make things complicated to the kidneys and the abdominal vessels. That was noted to have a higher prevalence among women. And when looking at just the last decade, mortality rates, thankfully, have kind of become more equivalent because they were worse for women before. And then typically women were presenting later, approximately 7 years later, with different features of the disease than men. And, that's going to require surgeons to really kind of tailor their approach to how they were treating women and to their surgical approaches. So that's important, but we have made great strides in kind of reducing that mortality risk in women. Unfortunately, still approximately 20% of patients with aortic dissection will die before reaching the hospital, but we can increase the chance of surviving if we detect it and we treat it promptly. And that, through Aortic Hope and through educational programs to help spread awareness, it's very important. And so if we look at risk factors for developing a thoracic aortic dissection, That includes, again, high blood pressure, a family history of thoracic aortic disease, smoking, heart disease, if a person has a known aortic aneurysm, because remember, as that aorta grows, if it goes undetected and that aorta becomes really enlarged, think of it as looking like the wall of a balloon. As the balloon kind of enlarges, that wall becomes thinner, and so folks are at risk for dissection at that point. We also have patients who unfortunately will have a connective tissue disorder, such as Marfan syndrome. And I didn't list the others, but the other ones that you may see are Ehlers-Danlos, Loeys-Dietz, and any of the familial inherited syndromes. Cocaine use, is in particular drug use, can create a risk for thoracic aortic dissection, as well as traumas and car accidents. Things where you could imagine that you would have high impact accidents to the chest area, and that can also cause an aortic dissection. And so when looking at aortic dissections, I saw that Aortic Hope kind of was also engaged in the Think Aorta awareness program, which is huge. When I was in practice, we did go around to some of our local ERs to spread awareness. We handed out posters. We really wanted to spread awareness around aortic dissection being an emergency that is fatal when missed. Very often patients will come in, they'll present with severe chest pain, but the first question they're asking is, am I having a heart attack? In fact, probably the first consideration that the ER physician is thinking is that it's a coronary event and not an aortic one. And so we often tell patients, with aortic aneurysms, that if you have a sudden onset of chest pain, if you have a tearing or a ripping pain, is how it's often described, go immediately to the ER. Do not waste time. But sometimes, unfortunately, the pain can present without chest pain. We've had patients that have presented when I was in practice to our institution with strictly upper back pain, or sometimes back pain that then develops, abdominal pain. They're not sure what it is. Sometimes we've had patients present to other places like urgent care only to be turned away because they thought it was musculoskeletal, and then they represent to the ER a few hours later and are found to have an aortic dissection, which of course was a surgical emergency. So that's important to really kind of pay attention to the patient's lifestyle and family history. And anything that makes you suspect that, you're going to get immediate imaging done in that ER to rule out an aortic dissection. We also know that patients can present with things like sudden shortness of breath, nausea, dizziness, even fainting. Loss of consciousness can sometimes be the first presenting symptom. And so how do we treat aortic dissection? Well, the approach is very similar. It's the same concepts as aortic aneurysm surgery, and that is, depending on the location of the dissection, the part of the aorta that's involved, you may still require open surgery, particularly if it involves the valve, the aortic valve, the root, the ascending aorta. In some patients, there are hybrid approaches, such as something called a frozen elephant trunk, where the person may have an open procedure and then the endovascular repair, the stent graft that you see here. In type B dissections, where the person tears just past the subclavian artery and down from the descending aorta to the abdomen, they may just be able to have a stent graft placed endovascularly. Again, that's minimally invasive. It's not open surgery, where surgeons will get access or make incision in the groin and then go up and under live X-ray, they would be able to inject contrast or X-ray dye and view your arteries and be able to deploy the stent that way. And then it also involves medical management, again, because blood pressure management, heart rate control is of the utmost importance in these patients. And so again, Cook provides disease-specific solutions. I first showed you our Zenith Alpha 2 device, which is for patients with aneurysms or ulcers of the descending aorta, but we also have this excellent dissection endovascular system. One part of it is our Zenith dissection endovascular stent graft. This is the fabric covered graft here, which surgeons will utilize to treat a type B dissection of the descending aorta, where the primary idea is to cover the tear. You cover the spot where that initial dissection happened in the hopes of cutting off all blood flow to that second channel, or that false channel that is pressurized. It's under pressure from the patient's systemic pressure and blood flow. And so you return normal flow through the aorta, through the original channel, or what we call the true lumen. And then we have surgeons that will opt to extend with our bare metal stent system, because what that does is it tacks up the true lumen to the false lumen and allows for what we call positive remodeling or healing of the aorta over time, without blocking the vessels to the kidneys and to the bowels. And so because it's a bare stent, you can see here the vessels are free to have blood flow. They're not blocked by fabric, and it allows surgeons to treat the initial entry tear and then to extend with the bare stent system and to positively remodel the aorta over time. Now, we don't just stop in the thoracic aorta. Cook Medical also provides innovative aortic care in the abdominal region for abdominal aneurysms and for abdominal aortas affected by dissection as well. And so here in the middle, we have our Zenith Flex device. This is an effective and durable stent graft for the treatment of AAA. And believe it or not, it's been on the market for several years. We have over 100,000 devices implanted globally. And then after that, we developed the Zenith Fenestrated AAA endovascular graft. You can see here by the picture that sometimes aortic disease in the abdominal region will encompass the kidneys and further up into the vessels that feed the bowels. And so our Zenith Fenestrated device can be ordered specific to the patient's anatomy with openings for those blood vessels customized to the patient. And we have had more than 20,000 devices implanted globally there. And lastly, we were excited that just this past summer, we launched the Zenith Iliac Branch device. We did have this available internationally. It just came to the US a few months ago. We're super excited about it. We've had actually internationally more than 30,000, devices implanted globally. And that's been proven to be a durable and effective way to treat these iliac artery aneurysms, while also providing a branch to the internal iliac artery so that we are not blocking off that internal branch and we are still able to treat the common iliac artery aneurysm. And lastly, Cook is not just a company that is just focusing on, innovation and products, which all of that is great and provides a benefit to patients and to our aortic community. But we're really proud to be procedural partners. Our aortic reps really take their job seriously and with great pride. And even when I was a PA, I could tell that the way that they were trained and their clinical acumen in the field was always excellent. They partner with the surgeons because, who knows our products best but the Cook reps. And so they will help to plan and size cases. If they're given a heads up, they can make a plan specific to that patient. And because we have such a broad range of sizes, diameters, and lengths of these stent grafts, the reps are important in helping the surgeon plan, which when that comes down to endovascular procedures, the planning is a major part of it. The deployment, believe it or not, may not take as long as one thinks versus open surgery. Many of our reps, if not all of them that cover aortic cases, do work on call. So when they are often getting called in on emergencies for aortic dissections, and will come down with a variety of products available to assist that surgeon. And so they really take pride in their ability to be procedural partners and to help ensure wonderful outcomes for patients. And we do take that seriously. We're not just procedural partners, however, we're also educational ones. And so these are just examples. Like last year, we did a type B dissection summit for surgeons, and we had people come into the Cleveland Clinic. Shout out to Drs. Roselli and Dr. Leiden, who you can see here in the picture. I think they were deploying our Zenith Alpha 2 device. We also hosted a sizing showdown at the Society of Vascular Surgery's annual meeting this past summer. And so throughout the year, our medical education team, who's just excellent in putting on these programs, will host something called a Cook Vista, which is an educational course for surgeons. But we also have a large presence at the bigger meetings, as well as regional meetings, where we put on events to help the next generation of surgeons better familiarize themselves with our products, and to kind of allow them to get their hands on these products and to practice with them. So it's been a wonderful partnership. Shout out to our medical education team. And shout out to Aortic Hope. We are super excited to partner and to collaborate with you this year and to increase community engagement and outreach for our aortic patients and for our aortic surgeons. So again, I just wanted to give a heartfelt thank you from the entire Cook Medical team and from me personally for having me on. Thank you, Rob.
You're welcome. And thank you for that great presentation. A lot of really, really good information. Uh, we can never really learn too much about our disease and causes and how they can be repaired and how we can manage them medically. And what you've done has been fabulous. Um, so I have a couple questions before we ask our audience that may be out there. But some things that I see and questions I get when I'm in our chat rooms and in our on Facebook and such in our support rooms. A lot of people wonder often how long are grafts meant to last? Are they a lifetime? Do they expect to wear out, or it's a common question.
Yeah, that's a great question, Rob. So here's the thing about grafts. But material wise, they're meant to last lifetime. In fact, when there have been autopsies, just as a person ages or end of life, unfortunately, but when they've done that, they have actually shown that a lot of these grafts are incorporated in the body. See, when the body recognizes something as foreign, it aims to heal around it. And so tissue will heal around it and incorporate it. And so those grafts last a lifetime. The reason why, however, patients may undergo reinterventions for aortic disease is not the graft themselves, it's the changes in the aorta. And so you may hear about things like an endo leak where there's blood getting around a graft, still kind of pressurizing that aneurysm or that dissected tissue. Where they may need an intervention, or the aorta kind of grew over time in that area again, or a person needs, a revision. And so the graft material is meant to last a lifetime. It's just that aortic disease itself is a progressive disease. And so as a person ages and as that aorta changes, patients may need reintervention.
Right. Okay. So it's the body doing its thing, and
Yeah,
sometimes it doesn't cooperate with the surgeon in the long
right.
run. Yeah, I get that because when we do hear about that, people, as you say, that have leaks, they complain, that it's at one end or the other, especially when they're replacing not the endovascular but the external ones,
Hmm.
that they form a leak or something like that. Uh, Another thing that comes up is, and I've always questioned, uh, is that people say in their rooms that, oh yeah, I've had my entire aorta replaced. Now, as far as I knew, that was not really a possibility because it's a pretty, it's its own organ and it's really large and long. So
Yeah.
can they do that, or is it really just a misunderstanding that of really what the organ is, and how much can we replace it at one time?
Yeah, good question. We typically tend not to do it all at one time. However, have I seen patients with multiple aortic procedures where they've, first had the thoracic and then they've maybe had a stent graft in the thoracic part, but in the descending aorta, and then did they have to have something in the abdominal aorta over time? The answer is yes. And so sometimes I've seen it a handful of times where patients have had quite literally almost their entire aorta replaced, but it's done in segments
Right.
because, as you alluded to, it would be super dangerous and not sustainable with life to do that all in one setting for patients. But as aortic disease happens throughout your lifespan, if the aorta degenerates, then we'd have to go back in and do something. And it is possible to have 2 and 3 procedures throughout your lifespan to fix that. I have seen people where most of the aorta has been replaced. It's not common, but it does happen.
But not one large graft.
No, not
That
one large graft.
it would
No.
seem just the surgery. I mean, to replace my aortic arch was an 8-hour surgery, eight
Right.
hour plus. If they were doing the entire, I don't know how long is it, a couple of feet, uh, that with all the blood vessels and everything that come off of it and all that work, that would seem to be
Yeah.
almost a superhuman task to be able to and the effect it would have on the body. I mean, the recovery would have to be
Well,
just
and that's the
terrible.
thing. It's just would be super dangerous. We wouldn't even consider it. I mean, you'd have to look at things like stroke, paralysis rates. You're not allowing even for the tiny spinal vessels. When you put a stent graft in, you have to allow for your body to recalibrate, so to speak, and to allow for the blood flow to adjust. You have to allow for the blood pressure to adjust and the heart rate, and it would just be an extreme stress on the body that we would not do that all in one sitting.
And all those risks are there for regular surgeries, and it's become
Right.
the more difficult you get, the riskier it is, of course.
Correct.
Um, so before, how do patients have when they get like a valve replacement, the doctors will often ask them, "Well, you want a mechanical or you want a tissue? Do you
Yeah.
want a counter pig or mechanical valve?" Do, and I've heard patients ask that about, can I choose what graft I get, what type? And again, that's to me, that would be, I would defer to my physician, to the surgeon and say, hey, that's your, ask me what kind of knife I'm a chef, what kind of knife to use or what kind of pan to use.
Right.
That's my job. But for you, you know, I don't know. But patients are, they're curious and they advocate. And do they really have a choice or in that?
It's interesting, Rob. I imagine that they would. It really depends on what the institution has, what they carry, what the surgeon is familiar and comfortable with using. The one thing that even in talking about cook reps is like even in planning and sizing a case, they're great at saying, hey, listen, if we don't have something for you, there are other options, to really keep the patient in mind. And so I think the patients can certainly express an interest of, hey, I want this particular stent graft, or I saw this, I researched it, this is what I'd like. If the surgeon is comfortable and familiar with it, and I don't see why not, I think they can make the request. But again, it really depends on what the surgeon likes to use, as well as what their institution carries. But I always say go ahead and ask. There's nothing wrong with asking that, with having a preference. If you're more familiar, or you've read up on outcomes and you really like this particular product, they should be open to. I mean, we used to have patients ask all the time, about their grafts or their valves, and we never got offended at that. I think it's okay to ask.
Sure. Well, then that's the advantage of having a planned surgery over an emergent surgery. Emergent,
Right.
there's no discussion. You're under, and
Yeah.
they
You
have
get
to.
what you get, kind of. Yeah.
Right. And as people know, as I know, at least they will then they fix the immediate problems, and that's why you often go back, like myself, a second time later, because they're going
Yeah.
to fix what really needs to be fixed to stabilize you and get you going, and then say, okay, we see the tears farther, and we're going to identify a new graft for that at a later time or whatever. Right.
Right.
Um, so, all right, last one for me. You were talking about women, and they used to be higher risk than men, and uh, now we're evening out, which I guess is a good thing. But how much of that you think was just personal thought, uh, was for misdiagnosis of women? Because women, historically have been turned away more often than men.
Yeah.
When men walk in the hospitals, like heart attacks, yeah, that's expected. Women, it's always something else. And do you think that was part of the issue? And now they've realized that this is, it's not just a backache.
Yeah, I fully agree with you, Rob. I think we saw it even, you alluded to MIs, to coronary events. It was the same thing of like, was it an atypical symptom? They don't always tend to present with chest pain in that arena. For aortic disease, was it the assumption that it was something else? Did they think it was coronary? Did they think it was just something completely unrelated? Was it, upper back pain? Was it heartburn, acid reflux? Was it the fact that they know that it by prevalence it's higher in men, and so they just didn't even consider it in women? The other disadvantage is when you look as a whole into medical research, I think sometimes historically women were underrepresented in the studies. And so that's also something to look at. And so all of that, luckily, as we said, the mortality rates are becoming a little more equivalent. I think we're a little more sensitive and aware of it. because they were presenting with worse disease, malperfusion, which is, the loss of the blood flow to the vessels because the dissection is creating this unstable blood flow to the kidneys and to the bowels, or like even with aneurysmal disease, they were presenting later, sometimes 7 years later than what you would expect. And so how much of that was a lack of awareness to screen the person for those symptoms?
Right. Luckily, we're doing better now, and with
Yeah.
our help and Think Aorta, our sister organization, so to speak, helping the medical community and people from companies like Cook Medical as well. So that is great. We have many, many thanks. Josh, do we have any viewers out there, and do they have any questions today?
We've got quite a few viewers today. Let's say hello to please and thank you. Terry, Molly, Christina, and Aldo. Molly says, "This is an amazing presentation. Thank you, Maysoon."
Welcome, my pleasure.
Terry says, "Yes, it is." Please and thank you say, "Nice pick of the team." Christina says, "Great info. Thank you." And Aldo Patricio says, "Hi, Mace," which I feel like you know what that means.
Yes, I do.
So you've got your own followers on.
I've got my own followers out there. Thank you, Aldo.
That's great.
Yeah, it's my pleasure. I think it's always important to break it down, Rob, for folks in the community. I briefly touched on family history, why it's important. I'll give you guys an example. This was a shocker. When I was still in practice in the aortic clinic, I covered with both cardiac surgery and vascular. We had a surveillance program. We had a patient that came to us, a woman who with a newly found aneurysm. Again, a lot of times these things are found coincidentally. I think she had presented to the ER. They were working her up for pneumonia and took a scan, saw her aorta was enlarged and referred her to our practice. When you asked her about family history, she had proceeded to tell me how her parents had told her that 5 of her paternal uncles and male cousins, 5 male relatives in the family had passed away all in their early 60s. And I thought, okay, was that ever brought up? Was that delved into? The answer was no. It was kind of a shocking thing to hear. So we ended up genetically testing her, and sure enough, it came back positive for a familial inherited aortic abnormality. So those are important to really ask about. And it's important to kind of get the message out to the community, particularly if you have aortic disease, that your direct family members, your kids, parents, brothers and sisters should be screened.
Exactly. Exactly. And if you can get it done, the genetic testing is great as well.
Yeah.
Those approvals are a little bit more difficult sometimes. I was lucky. They did it in the hospital after my surgery as just part of the program. Just, the geneticists come in and saw me and there it went. So, okay, Josh, you have a question?
We've got another question in the chat here.
Great.
Molly asks, in an emergency surgery like mine, what store did they shop at to get my graft and valve? I mean, what inventory does a hospital carry?
Yeah, that's a great question, Molly. So sometimes, depending on the institution, they will carry a variety of sizes of valves. You'll have your tissue valves, you'll have mechanical valves. There are even some that will carry, depending on their agreement, an arrangement of stent grafts that people can use, as well as the surgical, the fabric grafts, if it's going to be an open surgery. Sometimes if they don't have the breadth of sizes, you'll see this more in endovascular thoracic TEVAR grafts or stent grafts, then they will call a rep in. As I had said earlier, often our reps are on call. And so they cover these cases, they cover these dissections. At a moment's notice, they will bring the grafts in. And so it really depends on what the institution has on the shelf and how much inventory they're allowed to have. They will have the common sizes because we typically know where people sit in terms of valve sizes, in terms of commonly used aortic sizes. But if they need something outside of that, then they will often call the rep to come in.
Oh, it's interesting. So they keep boxes of stent grafts in their garage, basically.
Basically, they're obviously they're sterile. But they
Yeah,
keep rep stock and they bring it in if they have to, if the hospital doesn't have what they need.
that's pretty cool. Okay, another question.
Yes, we have another one. Please and thank you asks, to whom would you go for aortic abnormality screening?
So, assuming you mean like you want an initial screening for your aorta to rule out an aneurysm.
Oh, they're going to be about 20 seconds behind.
Okay, no
But
problem.
let's say
I
yes.
can. Let's say yes. So typically you can either address it with your family physician, or if you have a cardiologist, you can get that initial screening. Some folks will often start with an echo, a cardiac ultrasound. That will show us your valves, how they're functioning, and if the front part of the aorta, like the root or the ascending aorta, if there's an aneurysm there, it may prompt further screening with a CAT scan. The CAT scan can then be done in a way that will show us the rest of the thoracic and the abdominal aorta. So you can start with a family physician or a cardiologist typically. Sometimes, if patients come back and they're positive, then they'll be referred to vascular surgery or to cardiac surgery, because most of the time those are the folks that are kind of running their own aortic surveillance programs.
In that sense, again, people do ask a lot of questions or talk about their cardiologists, and you've seen that not all cardiologists are as familiar or as trained in aortic disease. They focus on the heart, and
Right.
it's not the aorta. And if you have a cardiologist that is not as schooled in aortic and vascular issues, I mean, what do they do? I've told myself or recommended people just to make sure that you have a cardiovascular practice where they specialize in both areas. So at least some of the partners or whatever are vascular specialists, or you say go to because if they don't know, sometimes they just don't do anything.
Well, true, that can happen too, Rob, or that, they are focused on other aspects of the heart, to your point, that they really don't feel comfortable. Some of them are very adept at following this because it requires continued surveillance, and others are like, you know what, our institution is great. There's an aortic program. These folks understand the nuances of the guidelines and the sizes and what sort of imaging or CT or MRI they want to get every year to follow this aorta. And so they may tend to just, send aortic patients to that program, to an aortic program per se, because they are so focused on the other cardiac elements, like, managing your blood pressure or your coronary arteries or your valves. And then there are some cardiologists that are quite comfortable with surveilling your aorta, especially if it's stable, it doesn't need surgery yet. A lot of them won't send a person to cardiac or vascular surgery until they feel like that aorta has enlarged to the point that it needs to be addressed.
So really, then maybe the discussion should be that you, as a self-advocate with your cardiologist, to just
Right.
ask that question. I mean, people can't be afraid to ask their doctors, are you comfortable with, aortic disease and the vascular disease, and I always ask, how many aortic dissection patients do you have, or have you had? Have you ever treated
Right.
one? Because it was very rare, and often it was, well, you're my first one, or that I've talked to, or the first live one, which was an issue before. You're the first survivor I've had. But so you can have that discussion, and if you're not happy with the outcome, then self-advocate and look for, as you said, there are more and more aortic disease clinics and centers opening up. Hospitals seem to be, as we discussed earlier before the program, hospitals are adding aortic centers as part of their practices now. So important
Yeah.
to get the right care.
It's very important. I think it's also, Rob, we've seen where the incidence is increasing. I think, sometimes that's also owing to a sensitivity of screening people, of having better imaging, where we're picking this up more. And so when that starts to happen, and having these dedicated centers is really important, unless your cardiologist feels comfortable. I think all of those questions that you should pose and advocate for yourself are very important. And don't ever be afraid to advocate. A lot of times it's important to bring someone with you to these visits. It can be overwhelming. You have someone there that can take notes and kind of sit there in a calm manner as an observer, as you're taking this all in, so that you can revisit that later. It's always nice to have an extra set of ears at these doctor's visits.
And sometimes the patient can be a little timid in front of
Yeah.
their physician. I mean, because it is, that they've got a lot going, and the physicians. I mean, they've done their work, and they're not there because they don't know anything. And a lot of patients can just, I guess, be afraid. But yeah, so patient advocates. I do know even people that are professional patient advocates and will,
Right.
accompany people to doctor's visits and so on, and ask those questions and do that. So if you're the type of person that is not comfortable being a self-advocate or asking those questions, or you don't have enough knowledge to do it, you can try and find your own patient advocate to go with you. Maybe it's a family member, or it may be somebody in your community as well that you can find.
Yeah, I absolutely agree. That's very important. I wouldn't skip on a patient advocate, especially if you know that you may be nervous going in there. You may not pick up on everything that's happening in the conversation, or if you're too timid to ask, it's important.
Absolutely. Any more, Josh? If we anybody come back with anything else today?
The clarifying question from Please and Thank You was, you mentioned about a familial link.
Yeah.
I feel
In terms of,
yeah, I feel like
yeah.
the answer you gave was pretty much the same, right? We're all
Yeah,
caught
so
up, right?
caught up. Yeah. The familial link in general, the reason why I bring it up is, when we talk about genetic testing, Rob, you made a great point. We made it a point towards the latter part of my career to really genetic test dissections that came in. Before, it wasn't a constant practice. Now we do that. But part of those genetic panels will also pick up, is this an inherited familial disease? And sometimes those would come back negative. But guess what? When someone tells me that 5 male relatives, all in their early 60s, at some point in their lives have had sudden death and passed away, if that doesn't come back positive on genetic testing, I'm still going to keep that in the back of my mind as a potential risk factor, because it just is too striking to ignore, along with the other risk factors, especially if we are screening the person for an aortic aneurysm and we're following them.
Right. And they're continually identifying new markers as
Right.
well. They don't know, all of the genetic markers for the disease. So, Josh?
We have another question coming into chat. Molly asks, back to the valve/stent store. Who chooses what brands a hospital carries? Do they carry multiple brands? Cook, Onyx, Edwards, St. Jude's, etc.?
Yeah, so let's use the example of valves first. Onyx is a mechanical valve that requires a lower. It allows you to have a lower Coumadin dosage, a lower INR threshold, versus say like a St. Jude or versus a tissue valve. And so often there are committees that decide this, but really it's up to the surgeon. So the hospital can give guidance of, okay, here's what we can provide, here's the range. Ultimately the surgeons get a say in what they want to use for their patients. And I'm of the belief that I think that should be the major deciding factor, is what do you believe in clinically? When I joined Cook, it's like, well, why Cook? Well, I believe in their product. We used to use their product all the time. Among other products, we carried multiple, but we saw what the outcomes were. We saw how well the patients did. I just gave you guys an example of like 30,000 implanted globally, or 100,000. And so we know what those outcomes are. So ultimately the surgeons will look at that, and they'll have familiarity from their training of all of these devices. They know what they like to use. And so they do get a big say in that. But some of that is also what the variety or the range of product the hospital can provide. And so very often there are committees where the surgeons are also involved in that decision making.
Great question.
That's a great question. Well, and I think it makes sense too, because we also have to be conscientious these days with the U.S. healthcare and the costs of things, right? And so those committees do also take that into consideration, the cost of products, and how much of it to keep on the shelves, and what the range is, how much stock do you need? But again, the surgeons are part of that decision making, which is the way it should be.
Absolutely. Okay. Anything else, Josh?
Let's take a look. Chat is caught up.
Okay. Well, great. Because that's about right on time. So, want to say thank you so much, Maysoon, and to you and to Cook Medical for their support and everything that you do for us and for aortic disease patients, and for taking your time to be with us tonight. That is much appreciated. And I want to say thank you to everybody for joining us tonight. It's always a pleasure, and we're glad you can be here. And remember, we'll put this out there on YouTube. It's now out here forever. You can come look at yourself whenever you want to, Maysoon. You'll be up here for the rest of our lives and beyond. It will live forever in the internet. So this is great, and I want to let everybody know again. Thank you for Aortic Hope. Hit the like button, the share, the little bell to remind yourself that we have more programming, and that we also take donations, and there should be a donate button. There will be another program on Thursday night that we have coming up, and I will be hosting that as well. So please be with us to watch that one as well. Same time, same place at 7. And my aortic addled brain is not helping me right now as far as the doing on Thursday. So it's Eaton, I think, is the company that I will be interviewing with. So, okay. And please, 7 o'clock, we will say thank you very much. I'm bringing it up here. Yes, I'll have Melissa Patty. I'm sorry. Just took me a second to bring that back up. She is an attorney discussing how to plan for your future on AHTV, which is another important thing that we need to do. It's always on the front of your mind, especially when you have planned surgeries, because we know there are risks involved, and there is risk in our life every day. So planning for the future is very important. So if you want to learn about that, you can join us on Thursday night interview with Melissa Patty. So I'm Rob Seltzer. With Aortic Hope, I want to thank again Maysoon Dayoub from Cook Medical, and Josh and the entire Aortic Hope community for joining us. And thank you and good night.